This is Dr. Yusafit Abarra. Welcome to our YouTube channel. Today we will discuss on one of the previous exam of Ermp, Ethiopian Medical Residency Program. So let's go. So a 28 years old female patient present to your clinic with skin lesion over the face, chest, and intrascapular regions. She also complained excessive oiliness of her face. On exam, her face is oily with papules, comedons, and pustules are seen on the above-mentioned area. What would most likely be associated with her condition? A, ovarian cancer, B, infertility, C, of polycystic ovarian tumor, D, myoma. Please pause the video and try to answer the question. So let's go to discussion. So if you say the answer is like C, you are correct. So let's discuss why polycystic ovarian tumor is true and the other choices are wrong. So first of all, this patient, who is a 28 years old female patient, have a feature of hyperandrogenism, which is explained by acne. So one of the feature of hyperandrogenism is acne. So these patients have definitely acne. So why do we say this patient have acne? One is the features, like the skin lesions, features of the skin lesion. One is excessive oiliness, and the other is comedon pustule. And most importantly, the area or the regions these lesions are present, like the face, the trunk, especially the back, and the chest. So this is a peculiar area in which the acne lesion are present. And the features is comedon pustules and excessive oiliness is one. So this patient have hyperandrogenism, definitely. So if or had it been ovarian cancer, this patient has age. One is the age, older age. This ovarian cancer is most commonly present with elderly age. The other is the clinical feature. Acne is not a feature of ovarian cancer. So if ovarian cancer will be the answer, this patient will have weight loss, loss of appetite or early satiety, abdominal distension, which more suggests ascites. This is not the answer. And then this is the most, the most wrong answer in this scenario. So the other is infertility. Had it been asked for this diagnosis, if it's the complication of such or this diagnosis, infertility may be. So we asked only about the associated condition. So with acne, with hyperandrogenism features. So the associated condition would be polycystic ovarian tumor. It's not the infertility. Infertility is one feature of polycystic ovarian tumor. But we are asked about associated condition, not the complication. So indirectly it may be, but we will not go for infertility. So infertility is still wrong, and we will discuss again for how it will be wrong in next slide. So the other is myoma. So myoma is wrong in this clinical scenario because acne is not a feature of myoma. Had it been myoma, this patient will present with the most common presentation being in addition to asymptomatic features, myoma will be present with, like a patient with myoma present with, if they are symptomatic, they present with abnormal uterine bleeding. And also, if we go to the fertility issue, it can cause like abortion, recurrent abortion. So it's not myoma is the other is on exam, on physical exam, you will find firm irregular mass in pelvic exam if the patient have myoma. So The answer is polycystic ovarian tumor. Let's discuss some points about polycystic ovarian tumor. So polycystic ovarian syndrome is a common endocrine disorder in women of reproductive age, characterized by one is chronic anovulation or oligo-ovulation. That means irregular. That means it may be regular, like it may come 35 to 15 days, or it may be absent for 2 to 3 months and more. So the other is hyperandrogenism. So clinical features like acne, particularly in this patient, hirsutism, androgenic alopecia. Androgenic alopecia in women is like, you know, like male pattern. It's almost the male pattern alopecia, which is thinning and loss of hair, especially on the forehead area. That is androgenic alopecia. So that there is biochemical evidence of high androgen, which is commonly characterized by elevation of the testosterone. So elevation of the testosterone. So testosterone will be elevated. Also testosterone will be elevated in hyperandrogenism, because when this is androgenous excess, so there will be high LH, so this will stimulate TK cells of ovary, and thus will increase the production of testosterone. So the third is polycystic ovarian morphology on ultrasound. So when we do scan ultrasound, we may see polycystic ovarian morphology in ultrasound. So from those three, the Rotterdam criteria is one of the uh, diagnostic criteria for PCOS. So in the Rotterdam criteria, if we do have found like at least two of the above three, so that is diagnostic for PCOS. So laboratory, like increased testosterone, as we discussed, and the other is increased estrogen level. So increased estrogen level in PCOS or polycystic ovarian syndrome is because whenever there is excess androgen, there is a peripheral conversion of this androgen to estrogen. So with the enzyme called aromatase enzyme, so excess androgen will be converted peripherally to the estrogen. So estrogen level will be elevated. So there is LH-FSH imbalance. This is this imbalance is the one which causes the chronic anovulation in PCOS. So comorbidities like DM, hyperlipidemia, and hypertension also common. DM because it causes insulin resistance, commonly caused type 2 DM. So obstructive sleep apnea, this patient, polycystic ovarian syndrome patient is obese, and obesity is associated with obstructive sleep apnea. So, by the way, I want to ask you in this, what's the most diagnostic modality for obstructive sleep apnea? What is the best one? If you tell me one answer for how do you diagnose obstructive sleep apnea? What you must your answer? Your answer should be polysomnography. So polysomnography is the best modality to diagnose. It is just a sleep study which combines different parameters. So this is the best one. So non-alcoholic steatohepatitis. So PCOS can cause hepatitis, which is called non-alcoholic steatohepatitis, because this condition like obesity, hyperlipidemia, insulin resistance, all leads to the excess fat in that. Those fat will be accumulated in the liver and can cause inflammation that is called non-alcoholic steatohepatitis. So endometrial hyperplasia and cancer. So why does PCOS causes endometrial hyperplasia and cancer. So, in this patient, as we discussed, there is excess estrogen level. So, this unopposed, by the way, one thing I want to ask to tell you that in this patient, in patient with polycystic ovarian syndrome, the progesterone is less. So there is less progesterone, so less LH surge and an ovulation and also unopposed estrogen. So this unopposed estrogen can cause endometrial hyperplasia, which can cause atopia and also can result in cancer. So whenever we found patient with PCOS, so you should have to screen for above those metabolic syndromes for obstructive sleep apnea. If the BMI, especially for the obese patients with BMI greater than 13 kilogram per meter square, so you will have to screen for them. So you will also go for endometrial biopsy to visualize if there is a risk for endometrial hyperplasia. So you should have to screen for them. For example, you will go for the uh, oral glucose tolerance test, random blood sugar, and like. So this is very important to do that. So the other is treatment. So when you come to the treatment of PCOS, so it depends on, for example, if you want to treat this patient's infertility, you need to treat an ovulation. So you need ovulation induction therapy. But from regarding treatments for PCOS, the first line is weight reduction. By the way, if somebody asks you what is the first line treatment for PCOS, it's weight loss. So weight loss can treat the ovulation. Weight loss can treat the abnormal or regularity of the menstrual regularity. So weight loss is the first line therapy for PCOS. So the other is for if you go for ovulation induction, letrozole is the first line. Letrozole, this drug. If you know this drug, it's the best one. Letrozole is the best one. And the first one, I know you are thinking clomifene. Yeah, it was first line, but nowadays most of the clinical trial shows letrozole has a higher live birth rate compared to clomifene. So nowadays letrozole is superior, especially in induction and with having a great or higher live birth rate than clomifene. So choose please letrozole if you have asked which one of the first line for ovulation induction besides weight loss. Weight loss is the first line, by the way. Then if you go for agent or ovulation induction agent, the first line would be letrozole. The other is menstrual regularity. So in addition to the weight loss, you will go for COC or combined oral contraceptives. What does this combined oral contraceptive does to correct the menstrual regularity? So in combined oral contraceptive, there is progesterone. So that progesterone will oppose the estrogen, or it reduces unopposed estrogen. So by doing so, when you reduce estrogen, the positive feedback of HPO axis will be ensued. So when that positive feedback is elicited because of decrement of the estrogen, then the GnRH will be pulsatile, and then LH, FSH will be produced, so the menstrual cycle will be regular. So that's the way we treat menstrual irregularity in PCOS. So don't forget weight loss. It's the first line. So thank you very much. Thank you very much.